implant illness in general, any questions one may have, and so that I can help with any additional questions in addition to what we are going to be discussing. So we're going to go ahead and get our different social media avenues on TikTok, YouTube Live, Facebook Live, and Instagram Live. So warm welcome to the new members who've joined the group. As you will see, the single most important thing that what I want my prospective patients or anyone who's listening, other plastic surgeons, residents, fellows, other medical doctors, to listen to and see what the patients are seeing. That's the most important thing, because you have to hear their complaints. And their complaints are very similar to the gist of the complaints that they present with. And if I may, if you look at the black box warning, and again, if I may, again, these are not my words, these are words from the manufacturer, for example, Mentor. And I'm going to read right here. Patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune disease, and others. So I'm going to stop here. This is by definition what is consistent and suggestive of what is breast implant illness. Individual patient risk for developing these symptoms has not been well established, period. Some patients report complete resolution of symptoms when the implants are removed without replacements, close quotes. So this tells you that BI exists and that there is a very defined way that the patients complain of the many symptoms. Not everyone has breast implant illness, and one way to gauge the symptoms is to fill out this questionnaire. You will see this on my website, and you will see almost all the 14 organ systems that are involved. Now, some may have one checkbox, many ladies have half, some have one or two columns, if you will, checked off. And these are the symptoms that the patients present with. So there is no lab test, there is no imaging test, there is no defined test other than the pattern that the patients present with. And the hallmark feature, the major problems, the most common problem is where the patients present with what is joint pain, fatigue. Then they have cognitive dysfunction, which is brain fog, muscle aches, pain, weakness, joint pain, soreness, which are the hallmark features of what is breast implant illness. Hair loss, a lot of patients complain of that. Not everyone. Remember, some will have some symptoms, some of them will have just a few symptoms, maybe transiently, maybe some worse during the winter months, for example. Weight gain, weight loss as well, easy bruising, temperature intolerance, low libido, autoimmune diseases like Raynaud's disease, Graves' disease, among others. As you saw right here, autoimmune diseases, for example, that's listed in that the black box warning paragraph. Night sweat, skin rashes, insomnia, estrogen progesterone imbalance, swollen tender lymph nodes in the breast area, throat, neck, tingling numbness in the arms and legs, burning around the chest and breast, cold discolored hands and feet, foul body odor. That is what some patients have mentioned before and even also after. Muscle twitching, vertigo, fever, dehydration, frequent urination, chronic neck and back pain, photosensitivity, nail changes, rashes, edema, premature aging, thyroid, adrenal problems, decline changes in vision, very common as well, slow muscle recovery after activity, liver kidney dysfunction, gastrointestinal digestive issues, food intolerances and allergies, chemical sensitivities, persistent infections, bacterial, fungal, suicidal thoughts. I had a patient today that I saw in clinics that she came in with suicidal thoughts, shortness of breath, heart palpitations, difficulty breathing, relatively uncommon, but it does occur in the young ladies. Oral thrush, symptoms, diagnosis of fibromyalgia, feeling like you're dying, chronic inflammation, recurring sinus UTI infections, interstitial cystitis, throat clearing, cough, difficulty swallowing, this trickle in the throat, very relatively common, if you will, headaches, dizziness, Anxiety, panic attacks, also a very common feature of what is breast implant illness. Mood swings, emotional instability, depression, very common. uh, Metallic taste in the mouth, symptoms or diagnosis of Lyme, and ringing in the ears. So I have my patients come and they check off the boxes. So just from today's clinic, you will see one patient had gone to 12 different subspecialists, from the endocrinologist, allergy immunologist, rheumatologist, and the patient had what is a complete, basically clean bill of health, and they were given these medications to help them with the relief, a band-aid of a problem solution, but not the addressing the underlying root cause of the problem. The other thing I want to mention here in that black box warning, and I wanted to see it again, not my words. This is the words that were listed on the Mentor advertisement from the manufacturer. This is the black box warning. Breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which require more surgery. So they're not lifetime devices. So a patient came to me and her surgeon had said that the implants are lifetime devices, which is absolutely incorrect. The manufacturers and the FDA will tell you clearly they last in the body 10, 15 years. So this one lady that came to me today, all the way from the Pacific side of the coast, she had what were a set of implants just from a year ago. I had another lady that came to me that had implants replaced just 3 years ago. So these are patients that have come to me as well with many signs, symptoms suggestive of what is breast implant illness, and they have gone to their respective primary care doctor, subspecialist, and all of that has yielded you're in good health, you're a clean bill of health, all the labs are normal, but the patients are definitely in a lot of distress. And so this is one way for me to gauge and see that breast implant illness does exist. And like I mentioned, over here, there's clear documentation that breast implant illness does exist, and that there is a real solution or a cure, because they use the word over here. Some patients report, quote, complete resolution of symptoms when the implants are removed without replacement. Now, the guest that I was supposed to have today, she had her augmentation in 2012, and she already had her explant in 2020, and she continued to have 50% of her symptoms continue to linger on. And then she sought me out, and then what I did was what is a residual capsule removal. That means I went in and cleaned out what the other surgeon did not feel comfortable doing, did not want to do, did not believe in, or did not do it wholeheartedly, or felt that he did. And remember, it is all about the sincerity. This surgery is all about that respect, that care, that attention to the detail, where the entire implant and the capsule and all of that inflamed tissue is completely, sincerely, definitively removed. In the majority of the cases, what is below the muscle directly on top of the rib, such that in my practice, I incorporate the fascia of the pectoralis minor, the fascia of the intercostal muscle, that's the fascia of the muscle in between the ribs, the intercostal muscle fascia, the periosteum, it's the layer directly on top of the bone part of the rib, the layer directly on top of the cartilage part of the rib, the fascia of the serratus anterior. So this is on the lower part, the posterior part of the implant. And then superiorly, I remove what is the fascia of the pectoralis major. So that's the inferior aspect. And so for me, the take-home message, we see a lot of surgeons doing videos where they're cutting open the capsule. So that's part B. So the take-home message for tonight's Facebook Live is you want to see your surgeon show the high-definition pictures of the chest wall, not only pictures, but videos of the chest wall showing complete removal of the capsule, because that is the ultimate of all proofs that the surgeon removed the whole capsule. I find that some surgeons, for example, are not putting the patient's initials, and you never know, it could be someone else's. Some surgeons basically are documenting end block was done, and you see the capsule has multiple tears in it. So by definition, it's not an end block. Some surgeons claim that they got it all, or cauterized or burned the capsule on top of the rib, and that is certainly indeed incomplete surgery. And the bottom line here is this surgery is all about that faithful commitment where your surgeon is truly dedicated into removing the capsule. And the way to gauge this is where your surgeon, preferably number one, is not putting an implant. So that's the single most important thing. If your surgeon is not putting in implants, then you have to further dissect and see, is he part of a bigger group, where in the group one person is solely sold on removal of the implants and the other two or three are putting them in, because then that nullifies that surgeon. Because remember, the big ultimate goal is financial gain on many surgeons who are now explanting. And as you will see, there is no standard. Every surgeon has had in their training, the end block is not done routinely, and that in the vast majority of the training programs, if not all, this is when the surgeon graduates, they're doing this as an in their private practice or on the job training, where they're removing the capsules in order to just, quote, if you will, please the patient. And when the going gets tough, and when the surgeon is given the task of removing that ultra thin capsule off of the rib, they then get tested and tried. And unfortunately, majority of the surgeons say out of their goodwill and heart that they do not want to remove the capsule because it's too risky. The general consensus is that the removal of the capsule is very difficult. It sure is. It is not required. It certainly is required. Look at the many patients who have had their implants removed with the capsules left behind, and they did not bounce back completely. And only when did these patients go back and get their capsules removed definitively, sincerely, completely, only then did these patients bounce back. And this is where you want to do the surgery once. You want to do it right. You want to do it in a manner such that if, God forbid, the implant is ruptured, or if the implant has some fluid around, it's all contained. And that, let's say if someone has their surgery done, absolutely the capsule is removed along with implant in en bloc fashion or 100% total capsulectomy. So that's number one. And number two, all what is removed is then tested. So in the Khan procedure, for example, you will see in majority of the patients do not need that unnecessary lift, because the lift is not required, or number two, it might be just too involved to do on the day where the 4 or 5 hour surgery was done. Number two, no drains are placed. It's been well over 5 years since I've used drains in any of my patients, even with the many ruptured implants. Number three, the capsules are always sent to pathology to rule out that rare BIAL-CL CD30 analysis, to rule out the squamous cell cancer, to rule out breast cancer. Number four, cultures are done for bacteria and fungus, aerobic bacteria, anaerobic bacteria and fungus. Number five, the implants are always returned to the patient so that the patients have a mental and psychological closure that all the implants are removed. And that the implant is indeed what was removed was what they were promised that they had. And lately, as you will see, one patient was promised he has saline implants and I removed silicone. One had textured implant, the other one was smooth implant. One patient had implant above the muscle, the other one was below. One patient in the remote past had implant that lot number did not match the serial number from the card that the patient was given. That's number five. Number six, the twilight deep sedation, where the patients are completely amnestic to the event, to the surgery, and that they relatively overall they have no recollection of the surgery, and it is a very good post-operative recovery. I do not do the general anesthesia where I paralyze the patients and then have the patients basically recover. That's still relatively safe, but overall, the twilight deep sedation with propofol, fentanyl, Versed is very effective, very practical, and gets the job done. And the seventh thing here is that all the patients, regardless of the age, comorbidities, get the same surgery so that there's no compromise. We saw the Facebook Live from last week where the 89-year-old got the same surgery as all the patients I did last week. Now, I see some of the patients are asking, can I ask a question? Absolutely. Please ask me any question and I'll be more than happy to answer. If I do not know, I'll be the first person to say I do not know. So please ask any questions. Yes, please.
So a patient would like to know, are you saying you remove the fascia or remove all capsule from these locations?
So the capsule, anytime you have any foreign body in the human, be it like a BB pellet gun, metal, be it a hip implant, be it a pacemaker, in this case, the breast implant, a capsule inevitably forms around the implant. And so that capsule has in it the toxicities, the badness that must be removed in order for the patient to bounce back and recover fully. So that capsule that forms around any foreign body, in this case the implant, that in it has what are leaching particles, that has in it breast implant particles, inflammatory cells, and that needs to be removed. Now that capsule tightly adheres to the fascia. So in order for me to completely safely remove the capsule, which super glues to the fascia has to inevitably be removed, because if the fascia is not, the capsule will be left behind. Now let me give you just today, for example, I'll go ahead and put this on. So just today, I had a pathology report that came back. Surgical path final report. Clusters of foamy macrophages. Macrophages are cleaner cells, inflammatory cells of the body that help with the inflammation cleanup. It says, quote, clusters of foamy macrophages and focal foreign crystalline material consistent with silicone with associated giant cell reaction. So they found the silicone within the right breast implant capsule. So that means if the capsule was left behind, the silicone was going to be left behind, and that small amount of silicone would be enough to continue. Now, in this case, what's interesting is this was in the right side. On the left side, it's benign fibrous capsule and fragments of unremarkable fibroadipose, means scar, fatty tissue, and skeletal muscle. And CD30 does not highlight any atypical cells. CD30 analysis is the stain that is done to make sure there is no the BILCL. So what is, now I did not know at that time when I did the explant on this lady on the 3rd of June that the right side was where the breast implant particles were. So that's why she got the best surgery she could, because we don't want to just remove the implant and say, well, if you have symptoms, then we'll come back. You want to do it right, you want to do it once, and you want to do it completely definitively. And in my practice, the capsule super glues onto the fascia of the muscle, the fascia of the intercostal muscle. So if you can imagine, I'm wearing if you can give me one of the gloves, please. Yeah, you can give me the top one, yeah. So if you can imagine, this my hand, these are the ribs. These are the ribs. And the implant is sitting right on top of the ribs, and my skin is the capsule. It's going to be so tightly adherent. Now I cannot peel this off, leaving the fascia behind. In order for me to completely remove the capsule, I have to remove this layer that's directly on top, and on top of the serratus anterior, the pectoralis minor, if you will. So that essentially ensures that I've removed the whole capsule. So God forbid if there's a break or a rupture of the implant, I don't want the silicone to spill into the chest. So that, and there's no harm or ill in it. So if someone gets a tummy tuck, or if someone gets a rib harvest for a nose, a rhinoplasty, you are not compromising the patient's chest. One day I was operating, and one of my plastic surgery colleagues right next door was harvesting a rib on a 10-year-old to reconstruct the nose after a trauma that he had under the nose, to reconstruct the nose. So it's not uncommon for plastic surgeons to harvest rib. Now, someone would say that's overkill. No, that's the standard of care. You don't want to get a cadaveric rib and reconstruct the nose from another person, which is still done routinely. I would rather use the patient's own rib, the cartilage part of the rib, to reconstruct the nose, which we do routinely and what is the standard of care. So if you're removing the rib from the same patient to reconstruct the nose, it's very normal and healthy. And remember, this is what the surgery entails, to removing the whole capsule. Anyone can remove the implant. It's all about the capsule. And this is, in my practice, the genuine, complete sincerity to doing the surgery right and removing the capsule completely. So hopefully that answers the question. I'm curious about the recurring mastitis that doesn't like to respond with oral antibiotics, only IV implants. So I'm sorry, I'm curious about recurring mastitis that doesn't like to respond with oral antibiotics, only IV and with implants. So remember, whenever you have any inflammation, so if you look at the many patients that come to me and patients who have implants, you will see majority of them have dilated veins, green veins that light up, small cherry red spots, what are called the hemangiomas, that's inflammation. If you will see, not all the patients, they have what is chronic inflammation around or within the capsule. We know from the many histological studies that have been done that any implant, be it saline or silicone, is placed into the human body, the body in itself mounts what is an acute inflammation and followed by chronic inflammation around the implant. We know this from the many histology slides that have been studied by the researchers when the implants are placed into the body. And so now the body starts becoming reactive. You see the giant cell reaction, histiocytic reaction, which are the histiocytes. You have the many macrophage cells, the foamy macrophages. These are the inflammatory cells that are noted around the capsule. And this is why doing the entire capsule removal right and complete is key in order to do what is a true end block. Now, the term end block is a cancer term, but we can extend this so that we can derive the meaning behind it, where the entire implant and capsule is removed as one system without a break in the capsule, such that whatever the internal contents are do not leak out, if it's fluid or ruptured implant or that weepy fluid that you see, so that all the badness is contained. So whenever you have inflammation, that does not necessarily mean it's an infection. So inflammation is basically what all these symptoms are, right? This is the body reacting to the inflammation. You have fasciitis, arthritis, uveitis, conjunctivitis. You have all these problems that the patients present with, autoimmune phenomenon, that are what are the hallmark features as mentioned by the manufacturers. Now, so the whole purpose of the surgery, now I have Ms. Delgado here, I have to say, I read what she posted on Facebook, and it is verbatim exactly how I would write it. What is the goal of the surgery? What is the essential gist of the surgery? You want to do the surgery once, you want to do it right. You want to do it with someone who accepts what is breast implant illness and who knows how to deal with it, who does it routinely. One of my mentors who trained me, he's a world-class plastic surgeon. He said, we live in the Motor City. If you have a transmission problem on a car, and this was an example that he gave us when we were in training, you're going to go to the transmission guy who does transmissions from 8 a.m. till 5 p.m. And that's all what he knows. If you ask him to change brakes, he's not going to do it. Now, if you ask me to do a rhinoplasty, I will tell you I'm not your surgeon. If you ask me to do a cleft lip palate, I'm going to say you have to go to a children's center. But if you ask me to do explant, I will tell you, for me, I'm very much vested and interested in doing this, because I myself, when I started my practice, I purposefully, deliberately chose not to do what is the most or the second most common procedure, or the most common procedure that's done in plastic surgery, which is breast augmentation, because I didn't want to harm. I didn't want to do a surgery where almost all the patients said one of two things. Number one, they wish they had never gotten an augmentation, or they wish they had gotten an explant done sooner, so that they could have reclaimed their lives back. And as you will see, do no harm. That's the oath that I took. And I didn't want to do a surgery where ultimately sooner or later, be it 1 year, like the patient I saw today that I operated on, or be it another lady that I did last week, 35 years later, that she had her implants removed. Today I saw two ladies that had saline implants. These were the nicer, better, safer saline implants, and both of them had their left breast implant ruptured. And now guess what? They are in distress, they are in pain, and they want to get this implant removed, and they dare not want to talk about any other augmentation or replacement because they had a very bad experience. Now what I'm going to do is I'm going to go ahead and look. There are a lot of questions, I believe, over here on TikTok that I'm seeing. So how do you know your surgeon did the right surgery? How do you choose your surgeon? Number one, forget everything that I have said, except for these 5 things that will ultimately attest, certify, give you the confidence that your surgeon is genuinely interested in doing the proper explant. That he, she, or the entire group that he or she is under is, number one, not augmenting, that they're only explanting, and they are very vocal about explanting and describing in the manner that they do. If you go to 10 different explant surgeons who are primarily explanting, you will see my technique is very different from the 10 others. Almost all the other surgeons are cutting around the nipple areola and down and basically making an S or a J cut, and they're making a vertical cut. Now in my practice, I say, and again, this is differences of opinion, I have the best exposure when I make a horizontal cut right in the inframammary crease. I'm able to hide my incision right in the crease, and I'm able to dissect parallel to the rib in a very safe, defined way. Majority of the patients that I see, the implants start bottoming out and they're down. And remember, when the patients had implants, they were 2 or 3 finger breadths below the clavicle. So I have to be able to dissect all the way up, and I'm able to look from a horizontal incision only. Almost all the other cuts are vertical, and I will tell you, it is hard for me to make a vertical cut and to be able to dissect parallel to the rib, because my dissection, my ribs are basically horizontal, they're not vertical. And if I make a vertical cut, I cannot dissect all the way right and left. Almost all the other surgeons are focused on the left, and I will tell you, I myself, I am not, because majority of the times, as you will see in my practice, 80% or so do not need that unnecessary lift. Now today I talked to a patient of mine. She is 53. She had 630 cc saline implant filled to well over 700, 750. I do not know, neither did she. She had a grade 3 capsular contracture on the right and a grade 4 capsular contracture on the left with ultra thin skin flaps and extreme inflammation. She had had this was her second surgery. And the bottom line is she came in with a lot of inflammation, and this was a lot of dissection and a lot of implant sitting on the chest or a large surface area. Now she will truly ultimately be needing a lift, like the 1200 cc or the 1000 cc implant. Now that is kind of an outlier, but majority of the patients who have 300, 400, 500, 600 cc implant, even the 89-year-old lady that we did the Facebook Live, she truly did not need a lift. And the point I'm trying to make here is that the horizontal incision gives me good access to the chest, and this is where you want your surgeon, number one, to answer the questions. You want your surgeon to be a firm believer in breast implant wellness to the point where they're not augmenting, they're only explanting. Automatically, that tells me that this surgeon now on average take 4 hours to doing an explant. If I were to do an augmentation, it will take me only 45 minutes to 1 hour. So that means in a typical day where I do 2 explants, I could easily have done 6 augmentations. And the point here is you have to take a big financial cut by almost 33, by almost 66% plus minus. So it takes a lot of financial commitment to give up augmenting. And this is where you will know that the group is not augmenting and that the surgeon exclusively is not augmenting and is only explanting, and that speaks volumes. So I myself, I will say I have no financial disclosures. The only disclosure I have is that I want my patients to improve. There is no financial commitment to any Facebook group. There is no patient traffic diverted to me from any financial Facebook group owner who's sending me information, who's sending me patients because of asterisks they have put because I donated to her cause or to the BII cause or to her Facebook group page, which unfortunately is happening every single day. And it is not fair, and if you ask me, it is unprofessional, unethical, and if you ask me, it's a Stark's Law violation. The second thing you want to do, you want to see that the surgeon is actively talking about and showing pictures and videos of the chest wall. That is by most supremely important. So you've seen the patient's chest and the patients themselves, not one, two. See, what I find is a surgeon does 10 explants and one is very nice. It's nice, crisp, it's a hard capsule, and now he or she is posting, look, this is how I do it. They have nice music in the background. This is misinformation, and this is giving the wrong illusion that this person is an expert in en bloc resection. You want to see consistently from one patient to the next that the surgeon is doing explants regularly and the patients are overall happy. You want to see pictures and videos from one patient to the next. I see one of the patients brought forth another surgeon's website and said, look at all those pictures. These are perfect results. And I said, these were all maybe model patients, maybe her out of the 50, 70, the best 6, 7, 8 that the surgeon has posted to basically lure the next prospective patient into saying, oh, these are all her results. That is misinformation and wrong information, and to give the patient an illusion that this is how the surgeon does it. If a patient has a radiated right side, it's certainly going to be a different result than the left side. If someone has a ruptured implant on one, and you want to be very careful as you dissect through and you see these pictures which are perfect looking because they have been photoshopped, they have been optimized, they have been taken out of another pool of pictures. So you want to be very careful that you see like the whole set of pictures that the patients are presenting with. Someone has a grade 4 capsular contracture on one side, grade 2 on the other. 3 weeks, 6 weeks out, you're going to have different results. Remember, it takes up to a year and a half for things to settle. So we talked about your surgeon is definitely not augmenting in 2025 and only explanting. Your surgeon is showing pictures and high definition videos consistently to all his patients, and that the high definition videos of the chest wall showing complete removal of the capsule and implant, and also cutting open of the implant and capsule on the table with the patient's initials on it with sterile gloves. That is very important because if there is the internal biofilm that needs to be cultured accordingly. Number 3, your surgeon is returning the implants back to the patient. So I find some surgeons rupture the saline implant or pull the fluid out, remove it, and then they try to remove the capsule. That is wrong. Number 4, your surgeon is making a generous cut, so the diameter of the implant dictates the length of the incision. I've seen so many operative notes where the surgeon removed the 500 or 400 or 300 cc implant from a 2 or 3 centimeter incision, or another surgeon tried to do an end block from the nipple areola. It can impossibly be done. How can you remove the entire implant capsule from the nipple areola incision? So the incision has to be the diameter of the implant essentially dictates the length of the incision. Number 4, your surgeon is basically sending the capsules off to pathology. One of my colleagues said, I don't like to send it because he literally said that the capsule in itself is the proof how I removed it and what are the dimensions of the capsule. 3 by 4 centimeters is certainly half of the size of what is a 325 cc implant. I would expect the capsular size to be 6-7 centimeters at least. And so that gives the patient and the surgeon an idea as to how extensive the capsule was, because anytime the pathologist receives the capsule, they basically put it on the table and they measure it with a ruler. And the point I'm trying to make here is that is the ultimate proof as to how the capsule was removed. One can always go back and look at the capsule and say, oh, this is kind of a mediocre dissection with a lot of holes and it cannot be en bloc. Or if it's a small piece of capsule that's removed, and I've seen those pictures on Facebook and the surgeon is using the word en bloc, very incorrectly. That is wrong information. You want to also assess and see that the surgeon has a track record of doing the surgery and describing it in a very defined, definitive way, such that he or she is talking about it very actively to the point where he's educating. Now, ultimately, it's the patient's decision to proceed with the explant if he or she, if she wants to proceed. If she has made the decision to proceed, and this is a big decision, you want to proceed with utmost confidence. You want to have done your work. I met multiple ladies today who came to me who basically signed up for the surgeries, and they said that they knew clearly, they had memorized my videos, my pictures, they have listened to pretty much all of my Facebook lives, and this is what I say, part of informed consent, so the patients know that what they're signing up for and that there is no surprises. You should approach your surgeon and say, I don't want to remove the capsule, which has happened to me before, and I outright refused to operate on that patient. This is that level of commitment that your surgeon must have, so that he's only explanting in the right and proper way, such that there is no capsular tissue or inflamed tissue left behind. Another Facebook Live that I did last week, I wanted to go ahead and see it. So the entire implant capsule was removed with the ruptured implant, and the patient had 2 masses that was on the periphery that I removed, which was an active extravasation and leak of the silicone from what is a ruptured implant. And that silicone granuloma was removed, and that mass needed to be removed as much as the ruptured implant that was all contained in the end block. So anytime there is any abnormal tissue that looks abnormal, feels abnormal, scar tissue, palpates abnormal, my sixth sense says is abnormal, I remove it, because I don't want to leave it behind, and that may be a potential burden for the patient for not improving and recovering from her many signs and symptoms. Now, another question that I saw is, one of the patients asked, do you get a mammogram on everyone? I talked to another patient today, and she has not had a mammogram in the last 15 years that, she's been past 40. Now, I will tell you, 1 out of 8 or 9 women will get breast cancer. The most common way is a self-monthly breast exam, if you read the literature, for picking up or diagnosing breast cancer. And the next most common way is a mammogram and the microcalcification. So literally, I will say millions of ladies have had early detection of breast cancer because of the mammogram. Now, mammogram still has a miss rate. As you will see, a mammogram is not your friend. A mammogram is not the ideal test, or the mammogram is not something that would be ideal. And I'm going to read the outline by one of the FDA guidance for industry and FDA staff in regards to the checklist for the patients. And we will have this for the patients to read. These are not my words. I did not write this. This is part of this, and we will have it be available for you. So this is on page 14, and I'm going to read verbatim. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer, period. Mammography can also cause the breast implant to rupture or leak, period. I should tell the mammography technician if I have breast implants. And then guess what? They want you to initial down here. They say, I understand that the long-term risk of breast implants may include painful or tightening of the scar tissue, which is capsular contracture, rupture or leaking of the implant, wrinkling of the implant, visibility of the implant edges, shifting of the implant, which is malposition, need for reoperation, reported in up to 59.7% of the patients. Now, this is where you will see, I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of the silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. A list of the components, chemicals, and heavy metals is available in the patient information booklet. So it leaks and leaches into the periphery, and guess where? The capsule is the first tissue that is incorporating slash uh, filtering slash stopping this silicon from migrating. And this is why, as you saw in the pathology report, there's silicon particles within the capsule. This is that A part that I read earlier. The other thing I want to mention here is recommended follow-up. Even if I have no symptoms, I should have my first ultrasound or MRI at 5-6 years after my initial implant surgery, and then every 2 to 3 years thereafter. If I have symptoms or uncertain ultrasound results for a breast implant rupture at any time, an MRI is recommended. Now, if you look at, they want to make it more practical. And the other thing I want to highlight here is, it talked about the heavy metals. Heavy metals found in breast implants: arsenic, barium, beryllium, cadmium, chromium, cobalt, copper, lead. And then you have the other volatiles and extractables that are noted. So the explant surgery, if you talk to 10 different explant surgeons, you're going to get 10 different answers. Many of the surgeons will say, well, let me go and see. First of all, the surgeon in general does not want to be told what to do, because it's the surgeon's ego, if you will. It's like, are you telling me how to do my surgery? Majority of the surgeons say that this is a myth, which is so unfortunate, because I just read to you that it does exist on the black box warning. Majority of the surgeons say, well, if the capsule is thin, I'm going to leave it behind. Absolutely wrong information. No matter how thin it is, it has to go. That is the whole gist and purpose behind the surgery. Many surgeons say, I'm just going to cauterize it because I feel uncomfortable dissecting on top of the rib. Then you should not do the explant and leave it up to someone who would want to do it. If you look at the general consensus, let's say the Canadian Plastic Surgical Societies and the health department for the country of Canada, and the gist of the admins here, the many plastic surgery societies in Europe and in the United States, they state that the explant surgery procedure is expensive. You bet it is. It's a 4-hour commitment on my end, and there's no shortcut into doing the surgery. They state it is risky. You bet it is risky to dissect off of the rib. If it was easy, everyone would be doing it, and no one would be cauterizing it. Everyone would be removing the capsule. And number 3, they state it is unnecessary. I beg to differ. How many of my patients have had continued misery, BII symptoms, when they explanted with another surgeon who chose to, who could not, who felt he removed the whole capsule and did not get it all out? And only when they did come to me did I remove the whole capsule completely, sincerely, definitively, wholeheartedly, religiously, honestly, respectfully, because that is what the patient needs in order to bounce back. And if you go to 10 different explant surgeons, I promise you, you're going to get 10 different answers. I hear of surgeons doing a fat grafting. Big problem for fat grafting in my eyes, in my practice. As you will see, fat grafting to the breast area will lead to some fat necrosis because of the fat that did not completely take. One patient I saw today had fat grafting to her chest, and she has had hives and irregularities and pain. So patients who have had fat grafting, they will say, and this is not coming from me, this is coming from the literature. If fat is injected on average 75 to 100, 125, 150 cc's, which is less than half of a Coke can, if you will see almost a good third of it gets absorbed, depending on the surgeon's technique and how they fan it out and how they spread it out, because you want to spread it out so that it will get incorporated by the blood vessels that will give it life. Some of the fat gets absorbed, and the body in itself basically absorbs it. Some of the fat will take good, that's the intended desired purpose. Some of it will form irregularities and nodularities. Now when you do your self-monthly breast exam, or when you get your next mammogram, it might pick up on these fat necrosis. So I had what I would say the top 10 hands down plastic surgeon in the United States. His patient came to me and they wanted to biopsy an area right next to the implant, and the breast surgeon was uncomfortable and the radiologist was uncomfortable doing a biopsy because they were afraid they were going to puncture the implant. There are patients who do a self-monthly breast exam and then they feel these irregularities, nodularities, and now as you can see, it's been reported in literature 8, 10, 15, up to 16% of the patients have mammographic findings that are, quote, concerning, abnormal, that may warrant an ultrasound or an MRI. Now, depending on how much of the fat is injected, there are mentions of 300. Obviously, the more you do, the more the chances are that you're going to have more fat necrosis. The technique of that fat, how it is separated. There are patients that report donor site comorbidities. There are patients who report that the breast tissue does not feel the same once that fat is deposited. Not all, a small subset. There are patients that complain of oil cysts that form, irregularities between one side versus the other. There are patients that report that they have contour deformities, acute and chronic pain, pins and needle sensation around the nipple. And so fat grafting to the breast tissue, if you ask me, just from the perspective of interfering with a self-monthly breast exam or a mammogram in itself is what I have called malpractice, bad medicine. I was sitting at a conference next to the chief of plastics at a major hospital, and I asked him, so fat grafting, in your experience, how many of those patients have problems with irregularities, abnormalities, mammographic abnormalities, and self-monthly breast exam problems amongst the many other problems? And he said, well, they do exist, but at least they look good. And I will say that 1 out of 8 or 9 women who will get breast cancer and who will have interference with this fat grafting, I say don't do something that is not smart or wise. Do no harm. Do no harm. That's the take-home message. Do no harm. And this is where, we have ample evidence out there. Ultimately, sooner or later, the patients will pay a price, be it 1 year later, or as you saw, 53 years later from the last Facebook Live that I did last week, and all the ladies in the middle where they will ultimately be, quote, lack of a better word, be hurt.
Dr. Pat, will you explain where you can find that? We have a patient asking.
Okay, sure. We will post this. So if you go, I want you to go ahead and I'm going to read this out so you can Google this. Breast implants, certain labeling recommendations to improve patient communication. U.S. Food and Drug Administration, U.S. Department of Health and Human Services, document issued on September 29, 2020, guidance for industry and FDA. This is where they want you, i.e. the patient, to initialize patient initials that your surgeon discussed all of this. Now, this should be happening to begin with before any procedure, and this is part of informed consent. So that when your surgeon sits down with you and says, risks of breast implant surgery, not my words. I understand that the risks of undergoing breast implant surgery, may include breast pain, skin or nipple areola sensitivity changes or loss, asymmetry, infection, swelling, scarring, fluid collections, hematoma, tissue death or breast skin or nipple, inability to breastfeed, complications of anesthesia, chronic pain, damage to surrounding tissue such as muscle, nerves, and blood vessels. If a capsular contracture, and then what I read earlier, and I'm going to go to the next page, impact on imaging of breast tissue may occur, but specific rates may not publicly be available in this. My physician has discussed these risks and approved and patient initials. I will tell you, then they talk about the risks of BIALCL, right? Very rare, but this needs to be tested and looked. Systemic symptoms. I didn't publish this. Page 13. I understand that some patients who have received breast implants have reported a variety of systemic symptoms, including joint pain, fatigue, rash, memory loss, and brain fog that some patients have called breast implant illness. While the causes of these symptoms are unclear, some patients have reported relief of these symptoms with removal of the implants and surrounding scar tissue, capsule. However, not all patients may experience improvement in their symptoms. Because remember, it might have leached into the lymph nodes and to the periphery. I also understand that some patients with breast implants have reported health problems in their children after birth or breastfeeding. It's disturbing just for me to read it, and then they want you to do their initials. Now, I will tell you the next thing. I understand that a breast implant is not a lifetime device, and the longer I have my implants, the more likely I am to experience a complication, and the more likely I am to require a reoperation requiring the replacement or removal of my breast implant. The other thing I want to highlight here is page 15 at the bottom. I understand that breast augmentation may result in permanent changes to my breast tissue, and if my implants are ever removed, I may be left with unsatisfactory appearance, changes to the size and shape of my breast, including but not limited to dimpling, chest wall concavity, puckering, sagging, or different incision size or location. Now look at the next line. This is a punchline. If I am an augmentation patient, meaning a non-cancer patient, any additional surgeries or medical procedures will likely be at my own risk. And guess what? Patient initials. Now, I will tell you, this is something, if I am a young 22-year-old college student that just graduated and I want implants, I should sign off on all the patient initials. Now, I'll tell you, if I read what I just read, I will run as far and as fast as I can from an implant. And this is the take-home message. Do no harm. Do not, it's not worth it. The 89-year-old, nice, super nice lady, these are her words. It's not worth it. It's not worth the pain, the misery. It's like you're playing Russian roulette. You could potentially get the BILCL, very rare of rare. Now, as you will see, the capsular tissue, number one, no one's interested in removing it. Vast majority of the surgeons remove the implant alone, leaving the capsule behind. Now, the capsule is not removed completely. Even if it's removed completely, it's not sent to pathology. Even when it's sent to pathology, CD30 analysis is not done, and the pathologist is not told you have to rule out the BILCL. It's missed, it's underdiagnosed, and it is missed. And not only the BIA, SCC as well, which is BIA, breast implant associated squamous cell cancer. And now you have one problem after another. Now, I will tell you, if you tell any reasonable patient with an open mind that if I sit down a group of 1,000 ladies who are interested in getting an augmentation and I read to you whatever I read, or they just listen to whatever, however many minutes I've been talking the last 20, 30 minutes, no one will get an implant. No one would want to get an implant. Why would you want to put your body through all of this misery and hurt? And I use the word that is ultimately only going to pay a price. And you do not know where you're going to end up. If 100,000 ladies get implants, eventually, 53 years later or 2 months later, you will be getting an explant sooner or later. I want you to please go to the Facebook Live I did on the 14th of April, and it's also on YouTube, and see what that 89-year-old lady went through and what I literally had to remove from her right chest, and how the fluid was literally hurting her, causing her discomfort, swelling, and her gait changes, among others. Even at that age, and I was not excited about operating on her, but I had to because this is physiologic surgery. In the middle of COVID, when every hospital was literally shut down and they were doing only essential surgery, at 9 a.m. Monday morning, prime time, I was doing an explant, and all my ortho, general surgery, all the other colleagues were saying, I have a patient with a rotator cuff tear or an ACL or a hernia patient. They were disregarding those patients. My patients took precedence because they were genuinely hurting, and the the operating room committee saw and knew firsthand that I was helping my patients. It's the most physiologic surgery where we're returning the patient back to their normal state of health. And the bottom line here is ultimately the hurt is there sooner or later. Now, the bottom line is they're not lifetime devices, so that eventually, on average, 10, 15 years later, maybe sooner or later, they will have to get them replaced. Now, do you have any questions from anyone?
Yes, do you take insurance?
So I will tell you, as you heard, the insurance says who told you to get an implant. Let's say if I were to get a facelift and I were to get an infection, if I were to go to the emergency room, they'll say, well, who told you to get a facelift? Everything related to that is on you. Now, some insurances are very smart. They say, well, to look good on paper, they will say that if you have a grade 4 capsular contracture, we will cover you. If you have fluid, we will cover you, or this quote rule out malignancy. If you have a rupture, we will cover you. But then deep down within, they do not want to cover the removal of the capsule because they say the standard of care is not removal of the capsule. What is this en bloc business, correct? Remember, insurance in the United States is a big scam. The number one reason for bankruptcy in the United States is medical bills. Insurances you saw with United Healthcare, the CEOs get rewarded. They get financially rewarded for saying no. AI, artificial intelligence, declines cases without even doctors approving of these cases, meaning their doctors deny cases right and left. So one of the patients that came to me from Florida, she needed to get an MRI done. I called the doc up for a peer-to-peer review in order to get an MRI approved for my patient who I was doing an explant on. And there was a question of a concern of a rupture of an implant during her first set of implants. So the first doctor that I talked to was a pediatrician. Then I asked that I should at least talk to a plastic surgeon. Believe it or not, I asked the pediatrician, have you even touched the breast implant in your hand? Then he said, well, we're not going to go into that. Then I requested a peer-to-peer. Then ultimately, believe it or not, an OBGYN, she is the one who approved the MRI because she knew I had already called 4 physicians and I was not going to give up on my patient. Another doctor that I talked to, the plastic surgeon from California, the big shot, his family medicine doctor took the phone call and I said, we should at least be talking to another plastic surgeon. And then he started questioning me and saying, why is an MRI indicated? And when I read this from the patient had Mentor implants, quote, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture, close quotes. He said, oh, okay, I get it. Thanks for educating me. The insurance companies are a big joke. They don't care about the patient. They don't care about the doctors. The hospitals, likewise, they're a financial institution, which their goal is to make money off of the patient. And ultimately, the burden gets passed on to the patient. So the insurances, even when they do reimburse, it's only a small fraction. The insurances don't pay anything for anything. So for that reason, I stopped taking insurance. If I took insurance, I would sign up for bankruptcy by the end of this week. Anyone who takes insurance cannot be doing the right surgery, period. You cannot justify 4 hours of surgery and you're getting reimbursed $600, $800, $1,200 because that will not pay even the electric bill, if you will, and the staffing and all the care and the precision that it takes into running a very elite facility such as the Landmark Surgery Center. And the bottom line here is, unfortunately, there is no ICD-10 code. There is no recognition of this entity. No one wants to even utter the word. I had a patient that came to me. She went to another plastic surgeon who did not want to even write down on a piece of paper breast implant illness. So when the patients do come to me, I go through their list of problems that I highlighted earlier. And then I write down breast implant illness, desire for removal of bilateral breast implants, essential surgery, non-cosmetic in nature, medical necessity surgery. If you think about it, this is the most non-cosmetic surgery. And the whole goal and emphasis is into removing such that the patient gets the best chance for bounce back. So if a patient gets her surgery done today, she has that utmost confidence that I will remove all of the capsule, inflamed tissue, and anything inflamed, even questionable, because it needs to go and it needs to be, number 2, tested to rule out all the badness so that the patient has the peace of mind that it was all removed and it was done in a very sincere way. Now, I am of the belief that it is a pure, genuine desire for the surgeon where he's not just quote doing one job after another, and that is made a factory. I spend the time with the patients before, during, and after, and I spend significant time with them because every patient is a challenge, be it above the implant, below, be it the implant above the muscle, below the muscle, ruptured, non-ruptured. Every surgeon has to be going and thinking the worst case scenario, that the implant is ruptured or there is fluid around the implant, and that if there are any abnormal masses, they're removed along with the implant. And it's a very thoughtful surgery. I talked to someone today, and her child was getting braces, $7,000, believe it or not. And this is the start is 5,500. And so this is something, if you ask me, yes, it is relatively speaking expensive, but this is something that certainly is worth every minute, every dollar, so that when the surgery is done, you have the peace of mind that it is done. The insurance companies don't want to pay anything. The number one will decline paying the surgeon. So anyone who says my insurance paid for it, I promise you, it was done incompletely and incorrectly.
I have another question.
Yes, please.
Is the MRI required for mentor saline or just silicone?
So saline implants do not require an MRI. That is only required for silicone implants. Saline implants are like a water balloon. When they do rupture, they rupture completely and collapse. And as we saw today in those two patients that came earlier, the left chest is relatively significantly less volume compared to the other side, which had an intact implant. And you do not need to get an MRI to show it was ruptured or not. However, silicone implants, as you saw the word silent rupture, you may have an exam that looks, lack of a better word, perfect. And I've gone into the surgery, and lo and behold, to my total surprise, the implant was ruptured. And that's why there is no physical exam test that is done. There is no mammogram. Remember, the purpose of the mammogram is to look for calcifications to rule out breast cancer. Ultrasound, it's a crude test, technician dependent. The ultimate test is an MRI, no radiation, magnetic resonance imaging without contrast, to look for the Linguini sign or a rupture. And that is the best test that's out there in 2025 that will pick up on a silicone rupture. And I don't get a MRI on every patient that comes to me. I get an MRI on those patients where they had a first set that was silicone, it ruptured, and now there was free-floating silicone, there's silicone granulomas. And now the surgeon put in a second implant and now walled off those pockets of free silicone. And when I do remove the implant capsule, the second set, I don't want to leave that silicone granuloma, silicone pockets behind. So for that reason, I want to know going in if there's any residual / silicone pockets. I can certainly go after them because the MRI can look at places where my dissection will not necessarily go, and I'm not going to dissect in the lateral pockets or the lower pockets. If the first set was, for example, 600, the second set was 250, I want to know what is in the periphery so that I get all the badness out. And this is where I quote mandate an MRI, so that when I do go in, it's like a Navy SEAL mission. When you come down the helicopter and enter a compound to get that bag, you don't want to be monkeying around. You go in, get the bag, and run out. You don't want to be cutting in and around the tissues and unnecessarily dissecting, because that will yield more trauma. The other thing I want to mention here is the vast majority of the patients have implants that are below the muscle. Whenever I do the surgery, I'm always below the muscle. The breast tissue above is not touched. I do not want to disturb the self-monthly breast exam. I do not want to disrupt the mammogram. And as you will see very soon, I will have a Facebook Live that I'm going to do with someone who actually was actively nursing. And I was able to do the explant in a manner where she continued to nurse the day of surgery. And I did her explant and she did very well. And I've done many patients like this where they continued to nurse, and there was no disturbance between the explant and the nursing process. So hopefully you found this informative. Why do doctors keep doing this to women? Now, I will say this to you. This is a very good question, and do no harm. As you will see, when I was in my training and I saw, I would say, thousands of ladies in my clinic and training and the fellowship who had implants, and whenever I saw them, I was very much, I used the word disturbed by the complaints, by the ruptures. Remember, from 1992 to 2007, the implants were banned. So ladies could only get saline implants. And I looked into it and I read it. If someone follows this Facebook page and you see whatever I see and I do in the operating room, you will only be convinced that the implants are not worth it. It is not smart, wise. And again, the whole take home message is do no harm. I would love to put in implants nonstop, right and left. And I'll tell you, there is no other better way of making a financial living, i.e., as far as in 1 hour, you basically get the same financial reward, if you will, as someone who's explanting where it takes 4 hours. Now remember, when I explant, the 4 hours are painful, tedious, meticulous. And I'll tell you, if I had not been trained in taking care of a patient with a gunshot wound to the chest, and patients where I had observed thoracic surgery, dissecting ribs off and reconstructing patients, a big part of my training would be missing. I spend a lot of time in and around the chest operating on patients with breast cancer, and that was an integral part of my learning. And as I do this con procedure, as you will see, where no drains, no lift, pathology is always done, microbiology is done, and you can certainly Google this, the twilight deep sedation, implants are returned to the patient, high definition pictures and videos, and all patients regardless of age and comorbidities get the same surgery. I kind of put the two and two together, and I welcome any surgeon to come in a very professional way, come debate me. I did not make this up. I did not make this up. I did not write up the pathology report on this patient, and neither did this communication where the patients have to sign and all these pages talk about the badness of the implants. I did not. Sarcastically, I will say, I wish I was putting an implant so, I could have a better neck, if you will. But the bottom line here is that do no harm. That's the take-home message. When someone signs up for implants, they're signing up for a lot of potential badness, maybe sooner or later. They're not lifetime devices. How many of the patients at the 10-year mark in the middle of their lives will say, oh, I'm going to go ahead and get an explant because my time is up? No, they run into problems before, during, after. We lead very busy lives. And remember, you want to do this surgery once, you want to do it genuinely, you want to do your homework, you want to have that absolute certified confidence in your surgeon so that when you look back at it, you say, you know what, you have all smiles, and that you have that confidence that everything was removed and everything was tested. One thing I will mention, one of the ladies mentioned this, the Facebook Live that I was doing today was with a lady. She had her explant done in 2020, and then she had continued to have the many symptoms of what is breast implant illness. And we'll set it up again with her. You will hear directly from her what the residual capsulectomy meant for her improvement, for her inflammation, for quality of life. She did her homework, and you will see, with all due professionalism, this is a surgery that you have to go in with that right mindset. You have to go in with that right confidence. You have to go in tackling this such that when you run into a surprise, you know exactly what next move you're going to make. So that ultimately when the patients go back to their states, to their home state, they have that confidence that the surgeon did the surgery in the manner that I describe in Facebook and YouTube. Today, I will end with this. I have two ladies I have to talk to who already have bought their day, and I have not even talked to them. That's how much confidence that they have in me into removing their surgery. Last week, I had a patient that came to me from a state where she went to the top 3 hospitals in the country. Her husband basically was extremely supportive. And then when he saw firsthand in the consult pre-op as to why and what I was doing, and it really sank in. And then when the surgery was done and he saw the Facebook Live, he said, I know exactly why you gave up that major mega hospital of the world versus coming here. And remember, it's the mindset, it's the surgical approach, it's the surgical technique. And as you will see, as the time progresses, how many times I've said this in the operating room, 20 years from now, the surgeries that I did last week with the Facebook Live, no one would be able to do it any differently. So having said this, till we meet again, please get your questions ready. I look forward to answering them. And it was an absolute pleasure to be on with you again. Take care and all the very best, and take care.